Hi, I'm John Swenson. So we're talking today about knee replacement. I think you can see on the feed that said, basically, if you have any questions, please call or write in or type them in or send them to us. First, just general things. In these days of COVID, I know a lot of people have been concerned about that. And so I think now, though, coming at least to our office, most all of our staff has had the vaccine. I know I've had both shots. My nurses had both shots. That's Kim, and my physician assistant, Lauren Labra, she's had both shots. So most of the staff is pretty protected. So I think people have always, for the last year, have been pretty concerned about, leaving the house, coming to see the doctor. But I think the environment here is about as safe as we can make it. And then on the other side, just so I'll be sure and cover it on the COVID side, with knee replacements, we're doing a large number of knee replacements on an outpatient basis. I know a lot of people don't want to stay in the hospital overnight because that's where COVID patients do tend to gravitate to. And so doing it as an outpatient, some people are spending as few as 4 to 6 hours in the hospital to get their knee replaced. And we'll talk in a minute about how we can get people to do it as an outpatient as well. But the hospital in the OR is sort of a separate building from where most of the COVID patients, from where all the COVID patients are kept. So it's connected to the OR by a hallway, but pretty much they're separated. And so we do some in the main OR, which is upstairs, and then we do some in the what's called the ambulatory surgery center, and that is in the main building, but it's a separate staff, separate way you come and go through that part of the building. So again, it's also separated from the COVID patients physically. So that's my COVID announcement. Want to talk about total knees. And really, I thought today, since we're talking about an outpatient, we talk about pain control, how the knees have improved, and a lot of it, this has been a long road from the old days of total knees to when in the old days people stayed in the hospital 2 or 3 weeks after knee replacement, and now probably half the people are leaving the same day, and most of the remainder are leaving the following day. So we get there by several methods. By one, decreasing how traumatic the surgery is in the first place, and then how we deal with it afterwards. So it used to be, the main way, we had a big surgery, we made big incisions, we made big bone cuts, we put a big implant in, and then the only thing we gave people afterwards were narcotics. And narcotics, if that's the only thing you're doing, you'll need a lot of narcotic. And then the downside of the narcotic is the nausea, vomiting, feeling sick. I think that drove people as crazy as possible, as much as anything else. So these days, we try and control pain on the very front end. So there have been some studies out there that have shown that if you have a traumatic event, you're in a car wreck, you have surgery with surgery that's very traumatic, and you don't have pain medicine on board or ways to control it, your brain, when it senses that pain, it remembers. So if the pain spike during your accident or during surgery is not controlled, then your brain says that's a problem, and it will remember the trauma, and you will have more pain for days afterwards. It'll take you a long time for the brain to calm down. So these days we try and control pain multiple ways. So we control it at the knee level itself. We try and control it on the transmission of that pain information, the information that comes from the knee as it goes to the brain, and then we try and control it at the brain level as well. So there are many different pathways we're working on all to control this. So I'll start in that way. We'll talk about the knee and then the transmission to the brain. So in the knee, when we do a knee replacement, and I brought a model, and I brought a partial knee, if that's indicated, generally that's a little bit smaller surgery, so people will often get over a partial knee quicker because it is less surgery. But truthfully, I'm going to talk really about total knees, because that's really where the focus. Total knees, there are probably 95% of knee replacements are going to be total knees, 5% or less are partial knees. So the vast majority of people listening to this talk will be thinking about total knees. So the knee replacement itself, replaces the surfaces on the bottom of the femur, on the top of the tibia. We resurface the back of the kneecap. So back in the old days, the incision was big. Everything had to be moved out of place. The instruments were large, and so to get them in and lined, everything was big, and so it required a lot of cutting, frankly, to get these big instruments in. And basically, you put your instrument, you open the knee up, and you just did everything from that spot, and then when you were done, you closed it up. So the change has been the instruments that we use now are a lot smaller, and so we don't need to open the whole knee up and do everything all at once. What we do is call it a mobile window. So you make a small incision, and we're now able to do it where you can save, and you don't have to go cutting all the way up this tendon. We kind of cut up just a little bit and then branch off, and that's much less invasive. It's called a subvastus approach, and people talk about a jiffy knee, and a jiffy knee is basically a subvastus approach, and that means you come up the side, and not all the way up, but just kind of very off a little bit, and then push it out of the way. And so what you do when you're doing that, basically you've got a mobile window. So I don't need to see the whole knee the whole time. I just need to see the part of the knee that I'm working on at that particular point. And when I'm done with that point, then by various positions of the knee itself, by various positions of the wound or the retractors, we go to the next spot. And so you're working on a little window here and there, and you kind of pull it around and move it around such as we need to. So in our goal of pain control, the first thing we do is try and do less surgery than we absolutely have to. So we're limiting the incisions, we're limiting the dissection, but we're still putting in the implant that works. We're still putting in a very conforming knee and tibial component. So during the course of surgery, after we've done most of the procedure, and the surgery can be done either with you asleep or with a block, and we actually kind of like the block if possible. That can be a spinal anesthetic or an epidural anesthetic where it numbs up the legs, but you don't necessarily go to sleep. Anesthesia is usually there, and they'll give you some of the twilight type medicine. So you can talk to the anesthesia beforehand and say, I would like to be nearly asleep. I don't want to remember anything. And they can give you appropriate medicines so that you're not intubated. They're not breathing for you, but you're fairly relaxed. You won't remember most of what's going on. And I've had other patients who say, I want to be pretty light. I don't want to be knocked out. And they'll converse during the surgery and much more aware of what's going on. It's not like at the end of the procedure, though, they could say, here's what happened, here's what happened, here's what happened. And still, it's a little bit foggy, but you can be more conscious if you so desire. So during the surgery, after the components, well, actually before the components are even in, after we've made some of the cuts but not all, we'll put what's called Exparel, which is a type of numbing medicine, but it's formulated in a way, they put it in little liposomes, which are little collections, they're like little fatty cells, if you will, that hold the numbing medicine, and we'll put it into some of the tissue that we've been working on. So the areas where the cuts are, we'll put this long-acting numbing medicine. And that medicine actually hangs around for about 3 days. So it's fairly effective, and it's helping to block those pain fibers, so that as you wake up for those 3 days, it's kind of like, when the dentist gives you a shot in the mouth, but it's hanging around for 3 days rather than when you get the dentist, it's only a few hours. So that is put into the tissue. Usually before the surgery is even started, we'll often put a block into the thigh, and that numbs the nerve that goes down to the knee itself. The anesthesiologist will do this. We started probably 6-8 years ago blocking the femoral nerve, which is a little bit higher than we block it now. So we block the nerve, and it would knock out the pain, but at that level it would also knock out some of the motor function. So if you talk to somebody that had a replacement back in that day, they'll tell you that they had to wear a brace for a little while after surgery because the nerve was numb and the motor function didn't work. We block it now at what's called the adductor canal block. We've been doing it for the last several years, and that we get the same part of the nerve that goes sensation. So it's still off of that femoral nerve, but it's after the motor branches have gone off. So you don't lose motor function, which is very helpful if you're going to try and go home the same day as surgery. So we block the nerve that goes to the knee. We're putting numbing medicine to prevent the transmission of the nerves and of the pain from the tissue. And then after everything's closed, we'll put some just regular numbing medicine into the knee itself. So all the cuts that we've done and most of the work that we've done is now being bathed in numbing medicine. And so all those things are stopping, between doing less surgery and blocking in 3 different ways, we're stopping the amount of pain that's being tried to send it to the brain. So our goal is stop it from getting to the brain and control it somewhat when it gets there. So all that's designed for the local control. If we do an epidural or a numbing shot, that helps with the transmission. So now we're not only blocking it here, but think of the brain up here. Now we want to get in the way of what pain we can't control. We want to get in the way of sending it. So the transmission lines. So we'll use various medicines. Actually, Celebrex, which is an anti-inflammatory medicine, is a COX-2 inhibitor. And so what it does, we give that to you actually before surgery even starts, and that helps to block the body's ability to send the signal of the pain from the knee to the brain. So we're kind of getting in the way of that. So transmission is one of the other pathways we're trying to block it. And once it gets to the brain, then we're trying to control how it perceives that signal. So first of all, we've made the signal less. We've knocked it down for what has to be there. We're not letting it get up there. And once it gets to the brain, that's where we do use, actually, Tylenol, oddly enough, is one of the things that will help on the brain level. So it works at the level of the thalamus. And the thalamus is the part of the brain that receives the signal. So it's the receiver. And then it goes to the cortex, which is kind of where you get your perception of what's going on. So the cortex is making the final decision as to what's going on. So at the thalamus level, once these signals have gone up through spinal cord and got into the brain, both narcotics and Tylenol are what's more effective at that level. So we give people Tylenol, and that's considered a COX-3 blocker. And so that helps with some of that transmission. We use either a narcotic, if you can tolerate it, or a medicine called tramadol, which functions, it's not a true narcotic, but it functions on the narcotic receptors, similar to a narcotic. Some people tolerate that better. Our goal is not necessarily to zonk you with the narcotic if we can get away with it, but then we have that as a backup, and we will use that as needed for the days after surgery. And then we're trying to, if we can control all those levels, control it locally, control the transmission, control the reception, we think that we can get a better way to stop the cortex, the brain cortex, from saying, oh, this is the worst thing that's ever happened to me. And instead it says, I'm not sure what quite happened there, but it doesn't seem too bad so far. And if we can block it at all those levels, that's what makes the whole experience a whole lot better. So generally, by doing all these things and not knocking out the nerve like we used to, typically most people are going to get up and walking and putting full weight on their knee 4 hours after surgery. So people have their surgery in the morning. If you have a 7:30 surgery, before noon, somebody is going to be getting you up and walking. And most people about 12 or 1 o'clock are going to say, I'm ready to go home. We will send people home with some narcotic pain medicine, and that's kind of to take as needed. But you'll find some people take a handful, 2, 3, 4, 5, 6 pills is all they'll take during their entire post-op period. And a lot of that is just blocking it from the start, never sensitizing the brain, never getting the brain so that it goes, oh my gosh, what happened? If you block it on the front end, you just don't get through that major pain.